Hello everyone. A warm welcome from me to today's webinar on pulmonary function testing during COVID-19. We know this is a key subject for all, especially during these challenging times. With us today, I'm happy to pronounce we have Dr. Frans De Jongh, a pulmonary physiologist from two university centers in the Netherlands, the AMC in Amsterdam and Medicentrum Spectrum from Enschede. In the last one, he's head of the pulmonary function department, and the first one, he's very much involved in the intensive care unit. So, Frans, a welcome from me, and thank you for being here today to share your knowledge and all your experience. The floor is yours.
Herman, thank you, and thank you for giving me the opportunity to talk about pulmonary function testing during COVID-19 and beyond. As stated, indeed, I work at two hospitals, one in the west and one in the east of the Netherlands. I worked in lung function testing already from 1989, so I think more than 31 years, but it really became big when I became head of the lung function department of the Medispectrum Tent in Enschede, which is one of the biggest hospital labs in the Netherlands. As you can see on this slide, I also still work at University Twente, where we try to develop new diagnostic methods to measure lung function from ventilated premature neonates till very old patients. So warm welcome, good morning, evening, afternoon, depending on where you are. Here it's around 2 o'clock in the afternoon. Of course, I have to show my conflict of interest, and I don't have any commercial conflict of interest. I'm working, a member of many national and international societies for lung function, and the most well-known might be the European Respiratory Society, the ERS, as you can see. NVALT, that's a Dutch Pulmonary Society. NVLA, that's a Dutch Respiratory Technicians Society. And the KHAG is spirometry in the first line in the Netherlands. The first question, and this should be an interactive webinar, and you have the option to vote, we have votes, and I give the floor to Maya for the first vote. And the question is, on this map, which you can see, where is the Netherlands? And there were these red circles for the option where the Netherlands could be. And I can see because like this. The green zone is the place where most of you might be at this moment, so around in the Middle East or in the Middle East. And the question is, in this case, where is the Netherlands? Is it in zone A? Is it in zone B? Is it in zone C? Or is it in zone D? And you may submit your answer, and we give you some time to see if the system works. Okay, I think I don't need any further explanations since 88% has the correct answer. Still about 10% thought it might be place A, and somebody thought it might be place D. Place A, well, formally, you might see this is around New York, and New York, as you might know, in the past was New Amsterdam. It was indeed a place of the Netherlands. But long time ago, Dutch people are traders, they sold it, and now it's already all, for centuries, not anymore property of the Netherlands. I don't think they did a good selling, but so you might have been partially right, but that was a long time ago. Place D, it's also a part where the Dutch people were active, but then it's a long time ago that they were active there. And place C is also, some isles are still part of the Netherlands. So in fact, most of the answers in this time were correct, but it's indeed in place B. And if we see a map of Europe, then you see here all the countries of Europe. then you can see that this small country here, which is at the North Sea, close to the UK and close to Germany, that is the Netherlands. So it's really a small country. And if you see the country itself, here you see the map of the country with all its provinces, then perhaps people might know Amsterdam or the soccer playing club of Amsterdam. And this here is Amsterdam. And there is the Academic Medical Center, which is the best known university hospital, which does a lot of research and where I do work since '89. And the other place in Enschede, which is close to the German border. Then you see here an aerial view of the hospital, which is a really new building. And as you can see in the background, I am at this moment in one of the rooms of my pulmonary function lab. At this moment, patients are measured in other rooms next to these rooms. And this last picture here is an aerial view of the University of Twente, where we try to develop new diagnostic methods for lung function measurements. So question 2, you now know the voting system is again, is the first real question. And this is, how many pulmonary function tests did you do before there was COVID-19? So was it about 10 per week or less? So if a year has 50 weeks, it's 500 tests per year or less. Or did you do 10 to 20 tests per week? So that's answer number 2, it's 500 till 1,000 for each year. Or around 20, and this was before COVID. Or more than 100 per week, so more than 5,000 per year. And it gives you an idea how big, how many tests you did. So try to calculate it, try to estimate it. How many did you do before COVID? And then choose your answer. And we again have something like 30 seconds before the answering option disappears. And here in the bottom, you see one of another room in my lab at this moment, where you already can see a big screen between the nitrogen washout device in this case, and another place where we do methacholine and histamine provocation tests. But that's for later on. That's not for this question. This question is, how many tests did you do before COVID-19? Okay, and I see that it's about an equal amount of shares. Some did about 500 or less per year, about a quarter. Also about a quarter, 10 to 20 per week. So about 500,000 years. Most of you, about 40%, did between 1,000 and 5,000 tests per year. And the minority did more than 100 per week, so more than 5,000 tests per year. To give you an impression, we did before COVID about 15,000 till 20,000 tests per year. So we were 4 times higher than the last option. But we are one of the biggest labs in the Netherlands. Okay, and the next question is, how many pulmonary function tests do you do now? So at this moment, this week, calculate how much you do this week, because it might change from week to week. Almost none, or 1/4 if I would compare it before COVID started, or we are back about half in service, or 75% in service, or around 100%. We are totally fully operational again. And this might, of course, depend in which country you are in, but it just gives us all a general impression how pulmonary function labs are opened at this moment. And if the answer is not completely, if you do 90%, then you say, okay, it's more close to 100, then you choose 100 instead of 75. So you choose the number which is most close to what you think it is at this moment. Okay, we see again that, let's say, each answer has some votes, and most of you, about 30%, so 1/3, is about a quarter back from back to normal. So 75% is still closed. But I see also 14% of the labs are again totally reopened. And I have to admit that we also are total reopened. And let's say a month ago, it might be 90%, but here in the Netherlands, we are totally up and running. The test which was done or reopened at last was the 6-minute walk test. But I will come back to that later. So not exercise testing or methylcholine testing or other aerosol generating tests, but the 6-minute walk test, because you don't want your patients to wear a filter while performing the 6-minute walk, and to walk with a distance free from other people for the 6-minute walk. That was one of the most difficult things to find. But we see that the majority is still, let's say, if I count 50%, then I have 21, 30, and 19. So I have 70% is at this moment running 50% or less of their opening what they did before COVID. So almost 3/4 is not yet open half or more than half. So then I hope I can say what we did and why we did it, how we could reopen the labs again in the Netherlands and some parts of Europe. And perhaps coming back to my introduction, I was a staff member of the European Respiratory Society. I'm still a staff member there. This is the biggest pulmonary function society in the world. And we did some recommendations together with the American Thoracic Society at the start of COVID, and are working on new statements, hopefully to be published, what we can do. One of the last questions, and then I will give a lot of slides, and then we have at the end one other question. So this is almost the last question. Almost the last question is, what is your main reason that you do less pulmonary function tests at this moment? PFTs, pulmonary function tests. Well, it might be the first answer. Patients do not like to come to the hospital because they're afraid that they will become sick in the hospital. Or personnel does not want to measure the patients because they think these patients might have COVID and I will become sick. And then my family at home might become sick. Or I would like to do it, the patients would like to do it, but my hospital has not enough financial resources, so not enough money to pay for all the protective materials which you have to wear, like face masks or like gloves or like gowns. Or, well, simply the pulmonary doctors, and you might be a pulmonary doctor, my colleagues are also pulmonary doctors, at this moment do not ask for pulmonary function tests because they think at this moment it's not yet appropriate. Or there is another reason, and if you have another reason, then there is a chat function. And in the chat function, you can type an answer. That you say none of these 4 answers is a really good answer. I have another good reason. And at the end of this session, we have a 15 minutes question and answer session, and then we might go to possible other reasons. And Herman raised his hands because perhaps he might already give some feedback during the chat. Or Herman, do you still have some comment?
No, sorry, somebody else raised his hands, but I will check this, sorry.
Okay. What is the main reason that you are not doing or are doing less pulmonary function tests at this moment? Patients will not come. The personnel, your staff, your respiratory technicians do not want to measure it. Simply a cost aspect is the main reason. The pulmonary doctors do, the chest physicians do not ask for it at this moment, or there's some other important reason. What is the most appropriate answer? Okay. And I see that the majority is that patients are afraid to come to the hospital. And of course, this is a very valid reason, because you think that the people who come to the hospital are persons which might have COVID or might be sick. And I can, of course, tell that the most the best which you can do in this kind of cases is that you must have a very clear statement, and I would say even advise a national statement, but as least an hospital statement, that you do all kinds of checks before a patient is allowed to go to the hospital, that you are certain that your people in the hospital, the patients in the hospital, are certain that they do not have COVID. So it's safe for you as patients to go to the hospital. And if your reason is another reason, for instance, you have some kind of cancer, you might know that it's very important that these kind of patients come to the hospital. But I have some other information on one of the later slides. But also personnel which doesn't want to measure patients. I had also several staff members who were afraid until they were vaccinated. Increased costs is luckily a minority, and still about 15%, so 1/6 of the chest physicians do not ask, and there are also 1/5 of people who have other reasons. But the majority, as I do see it, is that patients do not like to come to the hospital. I will try to come to that later on. So now I will have some slides, no questions anymore. And then to see how you can convince patients and your personnel, your staff, how COVID is transmitted. This is the way, which is a slide adopted from the WHO, so the World Health Organization, is that transmission can be due to droplets. You simply cough out droplets. It might be aerosols. Aerosols are normally seen as very small particles, very small droplets. In the less than 5 microns is normally seen, because these are found as being the respirable aerosols, so aerosols which I can inhale. Which and the last way of spreading COVID might be contact, and that is, for instance, shaking hands. And therefore, there is all kinds of protection available, and each kind of protection can have a different function. Some work very good for droplets, others just work very good for aerosols. And not touching each other is, of course, the way that you cannot spread COVID by contact. And one of the main things which people worldwide do is wearing face masks. And here you can see a slide in which you see how many particles of 0.3 microns or larger are filtered out by the different type of masks. And here you see an FFP1 mask, an FFP2 mask, an N95 mask, which is generally almost the same as FFP2, and FFP3. These are the FFP2 and FFP3 are mostly used in hospitals, or some countries they use N100 masks. They are equivalent to the FFP3 masks almost. And 0.3 microns is seen as the size of aerosol which could contain COVID particles. And here in this slide, you can see, which is taken from the University of Utrecht. It's another university hospital in the Netherlands. You can wear a simple surgical mask. You can wear an FFP2 or an FFP3 mask without a valve or with a valve. The valve is this gray part. This is the surgical mask. This is without a valve. This is with a valve. You can have something which you made yourself, a textile face mask, and you can wear a scarf. And then you can here see what kind of protection it does give. And then you can see it protects yourself, protects others, or is used in hospitals. And of course, it's very clear that in hospitals, we do not use textile face masks or we do not wear scarves because there's little protection from yourself or others because droplets might go through these textile masks. Aerosols will certainly go through these masks. So these masks, they might look correct, but in fact, they do not work that well. If you use a simple surgical mask, then you can see that it's an FFP1, that it filters out for 80% aerosols, but 20% of the aerosols can still reach your nose or mouth. So protecting yourself is stated as little. However, protecting others works quite well because the most way you exhale aerosols, it will be droplets or aerosols which go directly bounce against this mask, so will not be able to pass this mask. They are very effective in filtering those out if the airflow is through the mask. And you see that therefore these masks are used, they are cheap, don't have that much resistance, you can easily wear them for a long time. And you see that most countries say you have to wear them everywhere. And they work much better than something you make yourself or even a scarf. If you need a higher degree of protection, then you really can see you have an FFP2 or an FFP3 mask without a valve. And then you see that your protection is about 94 till almost 100%. Because, and it works, it protects in every cases, yourself, others, and it's used in hospitals. If you have one with a valve, then the air you inhale, the valve is closed, so air filters very well, so it protects yourself very well. But if you exhale, the valve goes open, and if the valve opens and somebody would be directly in front of you, well, then droplets and aerosols might hit that person, so it doesn't protect others that well. So with a valve, it gives a much easier expiration. You don't have any resistance if you expire. If you exhale, no problem for yourself, but it doesn't work well for protecting others. So in hospitals or let's say in primary care settings or everywhere where you want to see a patient, we do advise to wear preferably an FFP2 masks or at least a surgical mask. It depends, of course, how well you could screen your patient or the patient, the person who is who you are seeing, what is necessary. Okay. What were the advices we stated when you not should go for a pulmonary function test? And one of the things is, well, if the test is not urgent, and not urgent is defined as if the delay is there a delay in testing, it will not result in a short-term consequences. So if you had a yearly control test, a yearly routinely control test, and then you say, okay, can I skip it for 1 year because this, for instance, is a stable CPD patient, then you might skip it for a year. But if it is not urgent and it has some potential midterm consequences, so for instance, biologicals for asthma or for interstitial lung disease patients, you should think, is it worth that I do the test? Is the risk which I have myself and which I give my patient, is that necessary, or should I say it's not urgent enough? But some tests we didn't close our labs for that is urgent. If we delay the test, there is a direct consequences in less optimal healthcare, and mostly those tests had to do with surgery and chemotherapy, and for pulmonary patients, therefore mostly it's due to lung cancer. If I want to see if the condition of the patient allows still surgery, then I have to do an exercise test, and then I have to, of course, my patient cannot wear a mask. I have to wear full protection. I have to clean the room. I will come to that later in all kinds of settings. But in urgent tests, we never closed down. How to do the test? Well, how to do the test is a whole number of points. And perhaps it was not told in the introduction, but I think you as participants are able to see all the screens back after some time, perhaps already tomorrow. So this information you can, of course, make a screenshot or whatever, but publication, let's say the presentation, the webinar, you can still follow if you are now in the audience. The first is you screen your patients and if there are symptoms. And if you have a negative PCR test, then it's safe to do so. When we reopened our lab, we did for something like a month for all the potential patients a negative PCR test. So the patients had to come to a special room close to the hospital where they got a PCR test. Then 2 days later, we got the outcome of the PCR test, and if that was negative, then the patient was allowed to come to the hospital to be really measured. But after 300 consecutive negative tests, so all the 300 tests were negative, we stopped with that. If the patient is allowed to the hospital, preferably with a negative PCR test, always keep a physical distance. And the physical distance, some countries use 1 meter, other countries use 2 meters. Europe mostly use 1.5 meters. And that's depending on the health regulations which you do follow. And basically this distance, 1.5 meters, is seeing that if you exhale droplets, they will fall down within 1.5 meters. Aerosols not, they can easily spread for several meters. Perhaps one example, here you see in the bottom screen an example of personnel which is equipped with in this case, face mask and shield and glasses. What I sometimes do see is that people wear a face mask, but they put it that low that it only covers their mouth and not their nose. And of course, if you do it and you know that 90% of your normal respiration goes to your nose, breathing, it's much nicer, it's much easier. But all things which can go out of your nose, and it's also droplets if you sneeze, are then not filtered out. So it's always wrong. Always check carefully that if a patient enters the hospital, that the mask is worn correctly, so that also is over the nose and the mouth. And that's patients should wear the face mask. Use these barrier screens, which you already saw a glimpse on the first slide. So these are mostly plexiglass screens, but I will have another example on one of the next slides. Or protection covers, and here you see a face protection cover. Wear appropriate personal protection. So it might be a gown, like in the background. It might be gloves for your air. Be very well aware how your room is ventilated. I have the luck that I'm in a quite new hospital and we have a very high air exchange rate at my department. The droplet falls, so the time droplets are falling down and you can clean your room between 2 visits might be very low. If you don't have a ventilated room, then people say open the door and open the window and put a fan in that all the air is blown out by the fan out of the window, but then you might contaminate the outside part. Do not close the door and the window, because then air starts circulating around and aerosols will keep floating in the rooms. Preferably have a real room which has a very good filtering system itself. And after the patient left the room, clean all contact areas. So each part which the patient could have touched, or if a patient, for instance, was in a body box, as you see here in the background, and then the patient, of course, doesn't wear a filter anymore. If he then breathes, you have already to clean the walls of the body box, the seat of the body box, the door handle of your room. So clean all the contact areas. Okay, This slide is the most debatable slide, and this is still a slide which will depend from country to country. So it might, for some country, not be relevant. For other countries, it might be still very relevant. If you want to test a patient which already had COVID in the previous weeks or months, what should you do? Because this patient still might have complaints of dyspnea, so shortness of breath. Then the consensus statement at this moment is that when you want to measure a patient now, because the patient still has complaints but has not any signs of COVID anymore, no earlier than 10 days after the patient had 2 negative PCR tests. So the patient is free of complaints, has got 2 negative PCR tests. Okay, then you might measure that patient no earlier than 10 days after the onset of symptoms. If you have 1 PCR test, so 1 negative PCR test, then you have to wait at least 20 days after symptom onset, after patients who have COVID and at this moment are free of complaints. And then the most debatable, if you don't have any PCR tests because you don't have it as a country or they are very expensive and the patient has no complaints anymore for 30 days, and you really should be very well in, can you trust the patients or can you measure if the patient still has fever or has complaints? Because sometimes patients who might say, I want to go to the hospital, so I say I don't have any complaints, but they still might have it, then it's of course true what you can do at the check-in post to see if your patient still is or is already free of complaints. Lastly, if your patient has a problem with his immune system, so immunocompromised patients, then you should ask them individually, and 2 negative PCR tests are recommended. And herein you can see where we got the statements from. These are the references. What are relatively safe tests? Some relatively safe tests are tests in general where the patient can wear a mask or is connected to a filter. So it means that if my patient is there and I tested as much as you could do, that the patient doesn't have any complaints, the patient comes in the hospital a 1.5 meter distance. Also, your seating room has this distance of 1.5 meters. And then the patient goes to the room. We all have separate rooms here. All of my measurement setups are in different rooms. Patient goes in a room. The setup is already there, and if it's spirometry or you measure the so-called static lung volume, so body box or nitrogen washout systems or helium washout systems or SF6 washout systems, the patient is connected to a filter. So it's only a very short moment where the patient takes off the mask and is connected to the filter. It's also for CO diffusion the case. These are therefore relatively safe tests. And one of the most made mistakes is that if you do spirometry before and after a beta-2 mimeticum to see if there was reversibility, for instance, for patients with asthma or bronchial hyperresponsiveness, that some hospitals still use nebulizers. Nebulizers create a lot of aerosols. This is, of course, very unwanted. So if you want to do a reversibility test, use or autoinhalers as pressured meter dose inhalers, small puffers, or use spacers or dry powder inhalers. But don't use aerosol generating processes like nebulizers, because you might know they can create aerosols. But what to do then if you have a so-called aerosol generating procedure? And the best 3 or most 3 well-known procedures for that are the maximal exercise test, so the cardiopulmonary exercise test, a bronchial challenge test, and it might be by methacholine or histamine, or a 6-minute walk where you cannot have the patients walking with a filter. And of course, we did a lot of research if we could add a filter here at the outside of this mask. And in fact, you could do it. And for healthy volunteers, you can see that results are comparable. But patients will stop faster with their maximal exercise, and if your operation is depending on it, you should bear that your patient will not have a filter connected to the mask during a test, and that it might contaminate the room and everything which the patient touches or where aerosol can be reached. The same for bronchial challenge test. It means that your personnel must wear maximal protection, so goggles, gloves, shields, gown, and clean room and all equipment afterwards. And 6-minute walk I already talked about. The physical distance, I already said a bit about it. The CDC, which is an American regulation, the Center of Disease Control, stated 3 feet, 1 meter is enough. The WHO, so the World Health Organization, said 6 feet, so roughly about 2 meters. Here we work with meters. And therefore, in Europe, you see, like the Netherlands said, the consensus is 1.5 meters. Everywhere, in your waiting room, in your staff room, halls, everywhere, you should be able to fulfill. So if you have a very narrow pathway to your room, see if you have a one way in and another way out system, or otherwise have some kind of, I would say, traffic light system that you never can pass each other closer than 1.5 meters. And of course, still wear a mask. One-way path. And then one of the things is, if I have 2 persons of the same family, are they allowed close to each other? Yes, and then the debate is, what is a family? And family broadly is defined as people living under the same roof, because at home, and at home might be a family, let's say parents with kids. You also don't wear a mask normally at home if nobody is infected. But for instance, university students, they might share the kitchen or the bathroom together. So they are also sometimes considered to be a family, and they therefore are allowed to be close to each other if they can prove that they are living under the same roof. And so this might be the only thing where you can allow people closer to each other than this 1.5 meters. Room air exchange rate, a high exchange rate, it means 8, 10, 12 air exchanges per hour. That means the total volume of your room. So for instance, if your room is 2 by 2 by 3 meters, it's 4 times 3, it's 12 cubic meters. 4 times 3, yeah, 12 cubic meters. If I have 10 exchange rates, it means 12 times 10, 120 cubic meters per hour should be ventilated to have 10 of my rooms. Totally all air has gone out and new air entered the room. And you see that in modern buildings have these high air exchange rates. If it are hospitals, offices, it might only be something like 3 ACHs, air exchange rates. If you try to have a short exposure time of the patient, so patient is only very short in the room, and you don't say to the patient, oh, start already, just sit there, I will call you back in 10 minutes and I still take a coffee break or whatsoever. No, don't do it. Patient comes in, directly go for the measurement, directly again leave the room. If you don't have this room air suction systems, you might have suction systems with point suction systems, sometimes with ultraviolet light, which is very well in killing bacteria and viruses, or your room might have HEPA filters. Do not use airco and vent systems which recirculate room air. So this in front of an open window and all the air is safely blown out can be done, but not just one with the door closed and the room and the windows closed. Examples of protection systems in my hospital. Here you see a point suction system. Here you see very close above my nebulizer, there is a suction system, and if the patient is sitting here, and if aerosols would be coming out because the patient releases him or herself from the mouthpiece, air will be directly sucked away. Here you see a plexiglass barrier between the patient and the operator, so the respiratory technician, which also gives a safety that never droplets directly can hit my respiratory technician. If you see, and this is more for if you have more time later on, then there are considerations how you could conduct spirometry after COVID-19. And this is officially published by the American Lung Association already a long time ago. Understand how many % of your country does have COVID. Weigh the risks and benefits. Only do it when it's essential. Screen the patients before you do the test. Follow precautions for the patients and your personal, what is all safe. And it all gives all kind of points. You see here, there are 13 points which you can look for. And I've discussed most of the points, but if you still want to read it back, these slides can be used as details which you can read back later on. If you want to see more literature, then you can see the first recommendations we give as European Respiratory Society were placed on the ERSnet, but at this moment they are already off. These were already released 1 year ago, and here you have some other sources in which you can see, which are published sources about lung function labs and what you can do if, for instance, here there was a restarting a webinar after COVID. Is there some consensus statement about wearing a face mask in air geometry? Yeah, this is a recent publication. As you can see, it was in 2021, so from this year. And here, 2 people did a max test. And you can see one with the filter, that's the red line, and one without the filter. And you can see in both cases, the peak VO2 was almost comparable. It looked totally comparable, but the difficulty was these were only very well and healthy volunteers. And we also did this measurement. We did not publish them. Patients normally with the filter will feel that the air which they inhale is warmer, is more moisture, and they will go less far. So therefore we cannot recommend it to do it this way. But we do it therefore with the personal in protection, with cleaning the room afterwards. We never at this moment in any lab in the Netherlands have at this moment a proven COVID infection by the fact that somebody was tested for air geometry. What do you, does COVID, we are now nearing the end, does COVID have an influence on your lung function? This is one of the first papers, and this is from Japan, published last month, May 2021. And you can see that they measured 17 patients, and if you look in the results, they said that the majority, and these were all patients who had severe COVID, so they were hospitalized for COVID. So they had mechanical ventilations for at least 100 days after they had symptoms. There were pulmonary abnormalities. In almost half of them, there were functional abnormalities, and mostly it was CO diffusion, which was less than the lower limit of normal, roughly about 80% had predicted, and about 1/3 there was also a decrease in the vital capacity. So at this moment, the things we see most affect is vital capacity and the CO diffusion. For air geometry, there are not yet enough published results to have a clear statement if those patients are affected. So what happens if you do not reopen your lab? Well, the chest physician has a suboptimal diagnosis because he doesn't have the information of all your pulmonary function tests, and that results in a suboptimal therapy and treatment. And it might have short-term consequences, like consequences that you do not operate or do operate a patient which condition is too low. And one of the majority, which I learned when I still did children's lung function, I started doing lung function myself at premature neonates. So these were ventilated neonates of 26-30 weeks at the neonatal intensive care. If you lose your lung function, it's almost impossible to regain your lung function. And also, we do not know that if you have had severe COVID, if CO diffusion will come back to normal in 10, 20 years. You can consider it as a severe RDS infection, which also might lead to pulmonary damage for a longer time. What might be a future? Well, a future might be that we go to measure lung function at home. And at home means telemedicine. And it might be something like this kind of dedicated home spirometry systems. But sometimes these are still used in primary care settings as well. Or something which is visualized here at the right side, that you have some kind of tube which you can connect to your smartphone and that you blow yourself. Well, doesn't matter if you have COVID, yes or no, you only infect yourself or of course your family, and that does count as well. The most difficulty is for telemedicine and spirometry at home is that if you want your patient to blow optimally, so maximally in, maximally hard out, almost nobody does that correctly the first time at home. And even if you do it in the hospital, you have to sometimes let to do patient 3, 4, 5 times before the patient does grab it. And if he or she does it later at home, it might be still that the patient then does something like and thinks that's enough. No, that's not enough. It will give an incorrect answer, and it might even give an answer as if you might have a pulmonary disease, because your vital capacity will be lower than it really is. So now we are at our last question, and we have to vote again. After all the information you just got about how you can screen, how you can protect, how you can clean, how many pulmonary function tests do you think you can perform in the next week or next month? If your hospital, or you can convince your colleagues or the staff, or you are staff, do you think you can do with this knowledge? And we have the same answers as before. Well, I think next week the situation isn't any better, and I know these things do exist, but it doesn't help. Or no, I think we can open up more. What do you think you can do now? The question is now open for voting. Okay, I think we still have some seconds for voting. And the question disappears. The voting time is over. I think it will be now in any second gone. Okay, can we see the results? Yeah, we see the results. Okay, I see some shift. Again, the majority is about half, 50%, but 11% decreased to 3%. So almost none now is considerably less. And we see that all the other answers are now higher or considerably higher. Don't get me wrong, I don't sell any pulmonary function equipment. Fire asked me to give this lecture to you, and we work with their equipment, but I am not selling these equipment, so it's a total open for me. The last conclusion slide states that it's safe to reopen pulmonary function lab if you are able to screen your patients, if you can keep the correct distance and the correct cleaning procedures, if your pulmonary function lab is a safe environment and if you can clean it and ventilate it, if you wear the correct outfit and know all the procedures. And the nice thing is still now, there's no publications worldwide that COVID infections were reported in pulmonary function test labs. Don't get me wrong, 2 of my personal ones had COVID about a half year ago, but they got it in a home situation and not in my lab. We could all trace them down where they got it from. Your pulmonary function lab is safe. And I think Herman Goepenhoff from VIA has a visibility on the chat. And it's now time for the 15-minute question session. Herman, are there questions?
Yes, Frans. First, thank you for this nice and clear presentation. And yes, there are already 3 interesting questions, and I will read them for you. The first one is how frequent pulmonary function tests are recommended for the post-COVID patients according to age. And I put a little bit for myself to this because they ask how frequent pulmonary function tests are recommended. And I would like to ask also for myself, which pulmonary function tests are recommended to do in post-COVID patients?
Yeah, let's say the tests which are mostly now done is because we think there we see outcomes that lung function is lower. Spirometry almost never gives lower outcomes. So VCs and FEV1s are normally not give that much information. Vital capacity, however, might be restricted. So we see sometimes a mild restrictive measure and CO diffusion. So these are the tests to do. And if patients are short of dyspnea, also maximal exercise tests. These are the 3 tests which we do recommend most. And how much? Mostly these tests are done at least for every patient who was in the hospital mechanically ventilated. And let's say at least a half year after they left the hospital and are free of complaints. And then from country to country, it depends if these patients get it a half year and then again a half year later to see if there is improvement. The difficulty mostly is that you don't have any outcomes before these patients had COVID. So if you now had an outcome which is, let's say, 85% of normal, then you don't know if this patient before COVID was on 100% of normal or even 115% of normal, or if he or she was already at 85% of normal. This is the biggest difficulty. Normally a half year after a patient had severe COVID and then perhaps a follow-up period of each half year. But there is no strict regulations and it might depend from country to country.
Okay. Frans, thank you for this answer. And a little addition also, is there a relation to the severity of pulmonary function test results afterwards and the severity of the COVID, like the intensive care patients compared to the patients only or not even reaching the hospital? Can you already predict?
Yeah. Well, there are ongoing studies, and I have to say that we also, of course, do these kind of studies, but there's not yet any published information. What we do see, however, is that we think there is a relation. Indeed, there is so. You can compare severe COVID and if patient is ventilated on the ICU for several days or even sometimes several weeks, then you can compare it as a severe RDS and the outcome of these patients as well, vital capacity, SCO diffusion, as exercise VO2 max is more severely lower than patients who were not hospitalized. And one of the major difficulties is, however, that there might be people who had mild COVID. However, they had it for several weeks at home. And still, they have the so-called long COVID that they feel easily tired and dizziness and still not able to work that much or even to work at all. And the difficulty is this long COVID patients, which didn't have severe COVID, but still have complaints after they had COVID. If we measure these patients, we don't see any decreased lung function parameters. And that's a bit worrying, because the patients complain. We have all kinds of complaints. We are easily tired. After 5 minutes of walking, I have to rest. But if we put these patients on a maximal exercise test, for the 10 minutes that you have to exercise for maximal, we don't see any deviations from normal. And then the test, they can say later on, the whole week I could do nothing anymore.
Yeah. Okay. Thank you for this clear answer. And in addition, I still think you need to do the CPAP test to rule out that there is something with PFT. But sorry for my intervention. We have already another thing.
Correct. If you have a patient with unexplained dyspnea, and it might be due to post-COVID, any patient with dyspnea you cannot explain because the lung function might be normal again or above the lower limit of normal, then the test you should do is a maximal exercise test. But that's for any patient with dyspnea, also the post-COVID patients with still any complaints. You're right.
Thank you. And I can already say to you, we have another 8-9 questions. So try to be brief, short. But it's also my problem.
No,
do you call the patient if a staff who had discovered COVID? Do you call all the patients who visit your lab after one of your colleagues was positive tested?
If somebody who was positively tested was positively at my lab, I had, of course, to put my whole lab in quarantine, and I might not test anymore. However, as stated, the person who was positive for my lab was tested positive at home, and therefore never was positive in my lab. So therefore, we didn't have to close the lab.
Okay, thank you. Oh, this is an interesting one. What is your opinion regarding the ultrasonic flow sensor safety? Since, as far as I know, mouthpieces are totally open without any filter. Many things.
Yeah, that's correct. Most times, if you use an ultrasound, it was designed to have no filter, and then any air goes through, and then you should consider it as an aerosol generating procedure. So then also spirometry should be treated as methylcholine or as an exercise. So you then have totally to protect your complete environment, your personal, clean everything afterwards. So it gives you a lot of extra work if you use these kind of systems. And I know there are some ultrasound systems which, due to COVID, also now can have a filter connected at the backside. And this is explicitly stated by the manufacturer. And then there are new recalibration tables for this kind of equipment with filter. But not all manufacturers have that. But some are designed that you can have a filter at the backside of the ultrasound and correct for that, because otherwise you get wrong answers.
Yes, and our ultrasound sensor only works with the filter, but to have this stated here, I don't know. What is your opinion? What one PCR test prior 84 hours is recommended? Like, is it, how long do you have, how long before you did the test is the PCR negative test still valid?
Yeah, let's say that's I would almost say it's the same if you want to go on holiday to a country abroad. If you have a negative test, it's valid for 2 days, and after 2 days you have to do a new test. So 48 hours is the validity of the test. And if you then, if the patient comes after 4 days, you have to say no. Then you have to do another test if you require a PCR test.
I just go on with the question. Thank you. We've come a long way. And in relation to the success of vaccination programs and the needs for all to live with COVID, with this in mind, should we still have the cautions we have now still needed over a year? So I think the question is about.
That's well, we are lucky that in our country at this moment the vaccination rate is something like 65% and one of the highest at this moment in Europe. It's also proven that at this moment more than 99% of patients which are in hospitals due to COVID were people who are not vaccinated. So if you have your double vaccination, if you're totally vaccinated, the chance that you end up in hospital is less than 1%. So indeed, if your country has a very good vaccination program, and you are, let's say, over 75%, then you could release most measures, and we don't require any PCR tests anymore in our country because of the high amount of people who are vaccinated.
Again, thank you. Descogen, so the power, is this disinfectant effective enough to disinfecting the pneumotax from our JLab systems? It's a hygiene question.
It's a hygiene question, and basically I would say I have to refer to the manufacturer.
Yeah, you're right.
So perhaps you can answer yourself this question, because to be honest, I don't know if I can give a correct answer.
No, so we will answer this later, but I think yes, but we will answer this personal by email by our hygienist. I think this is the best way to do it, the most professional one. Also, like filters cost more than the test give as reimbursement and this is about Argentina. Should we still do per spirometry at all? But of course, it's an economical question.
Yeah, let's say we did in the most European countries, also in our country, before the Mexican flu, half of the hospitals didn't use filters. For us, one filter, filter, clip and a mouthpiece, it costs about €1, but we buy them more than 10,000 each year. So we really buy a large quantity of these. And then it's about €1 or $1, whatever money you prefer, for material. And let's say my personal cost for one spirometry is considerably higher than €1 or $1. So for most countries, if you buy a high amount of equipment, it's quite cheap, and it should be much cheaper than the tests of one, the cost of one test, or the reimbursements for the cost of one test. For instance, what a health insurance system pays.
Okay, thank you. So I already mentioned, and we will try to answer all the questions also by email, which we cannot cover. So we are already a little bit over time. So I do a little. This is one interesting. So we were masked in the streets. So why can't we not do a 6-minute walk test wearing a mask?
You're correctly in that. Basically, of course, you can do it, but if you know your patients who normally walks a 6-minute walk test, these are patients who sometimes do not walk more than 200, 300 meters. And they will again be this very severe patients. They will be walking less far if they have to wear a mask. They already the idea that they wear a mask, they feel short of breath, and they will already do less than what they normally can do. And that's the reason that again, healthy volunteers, no problem at all. If your patient says, "I'm not hindered by my mask," okay, let it be. If the patient is hindered by the mask, then you might think your outcome will be not the real outcome, but the patient could reach without the mask.
Yeah, and I think in the comments it's very important to mention this was one with a mask. I think we should finish with the last two questions, which are spirometry with open windows. May this be appropriate?
But let's say normally you want that your room, all the air is out of your room. So if you open up a window and the door is closed, then normally air will not move in the window, in the room at all, because air can go nowhere. So normally then you want to have an open door, and at the other side there is also something open that you get flow through your room, entering the door in and the window out. But if you open two windows next to each other, then you get almost no fresh air in the room yourself, and it doesn't work.
Okay.
Aerosols might even then start to circulate in your room. Then you should really put a fan before your open window and let the fan blow the air out of your room.
Okay, thank you.
Then it works, and those fans cost nothing.
Okay, I apologize already. We go a little bit over time, but I think this is also a very interesting question about iOS. Do you recommend to perform iOS test as a procedure requiring only tidal breathing? And also in relation maybe to the post-COVID damage in the small airways?
Yeah, this is an interesting question. And of course, there are two options. If you're certain that your patient doesn't have COVID anymore, then you could do it. And mostly you don't want to have resistance placed or so filter placed. You can also think, do I do the test with a filter placed in fonts, but then the calibration already with a filter in place. So your iOS with a filter, and then to connect the patient to a filter. But normally you don't want this filter there because you want to have as clear resistance outcomes as possible. So we do them without a filter, but it might indeed give outcomes about the peripheral airways. However, till now, I didn't see any publications in this field.
Okay, thank you. Now the last one to close this interesting meeting. I think it's, I don't know if this is a difficult one. If you have a negative, do you still need a negative PCR test if you are fully vaccinated?
Well, this is an interesting question, of course. If you're fully vaccinated, you still, of course, can bear, you can have the virus itself and you don't feel any sickness, but still you can spread it. Like I stated, we did, after 300 negative PCR tests, we did a more simple screening about temperature, about coughing, about shortness of breath, about smell, about loss of smell, fever, all these kind of questions they have to tick in. And if everything is negative, then the patient is measured. If he or she is vaccinated, yes or no. If he or she has a need, and he or she doesn't have need a negative PCR test. All my employees are already long time double vaccinated, so they feel safe, and therefore we don't require this negative PCR test.
Okay, thank you. And a big thank you again for the complete presentation, Frans. Also, thank you for the attendance to all of the attendees for this webinar. Hopefully it was very interesting. And the few questions we could not answer yet, I recognize a few were hygiene related. We will answer by email. Okay, then I will close this meeting.
Okay, thank you.
Okay, bye.
Bye.
Bye.